Thank you, Habiba. Hello, everyone, and welcome to this cross-regional roundtable where we will be discussing our experiences, how our educational environment was hit by the pandemic, and what we did to ensure continuity. We will find, of course, common grounds among ourselves, and we will certainly learn from each other. But I'm sure that this format of synchronous online discussions is here to stay. So again, welcome everyone, and I hope you enjoyed this activity, and I leave the floor to Dr. AAHCI.
Good morning, good afternoon to all participants. It's been an honor to be here in this joint meeting, and I'm representing the Latin American and Caribbean region, which has 3 different countries. We have Mexico with 3 institutions. Mexico with 1 institution, TechSalud, Colombia with 3 universities, so Javeriana, Rosario, and La Sabana, and Brazil with the University of São Paulo, my alma mater, and which I represent. We are right now the current headquarter, and we are honored to have this joint meeting because I think it's a golden opportunity to exchange ideas and to create new ones. And hopefully we'll establish a long-lasting relationship and exchange. And I'm really grateful to the Association of Academic Health Centers for all the support, and also the MENA region. So especially to Professor Shadid and Professor Bahous. It's been a very, very fruitful collaboration. Thank you and have a nice meeting.
Good morning and good afternoon, and welcome to everyone for the first LAC-MENA cross-regional roundtable on disruptive transformation of the learning environment, sharing experiences and best practices from around the globe. This event is in conjunction, of course, with the upcoming virtual annual meeting of AAHCI, themed Leveraging Lessons of the Pandemic to Accelerate Evolution of the Academic Health Center, being held today, the 27th through October 1st. It's a distinct honor to be hosting and facilitating this roundtable today, and a delight to have you join us from both sides of the Atlantic. I'm Dr. Nancy Shadid. I'm Director of Student Affairs at the Lebanese American University Gilbert and Rosemary Shaburi School of Medicine, where I'm also on the anatomy faculty and I coordinate our website. My background is in reconstructive plastic surgery and hand surgery, and prior to coming to Lebanon, I practiced for many years in Boston at the hospitals of Harvard Medical School. I became involved with AAHCI 3 years ago when I was lucky enough to speak at a regional conference at American University of Beirut. And even since that short time ago, we've seen the organization grow and diversify, I would say blossom, with the expansion of virtual platforms, prompting collaboration across the globe. And in our case, recently established affiliation between our institution, LAU, and our co-host in this event, University of Sao Paulo. So the impetus for this roundtable is clear. The COVID pandemic stimulated dramatic and in many ways what will be permanent changes in medical education. While we may have already had access to technology before, the pandemic was like the rocket fuel that forced these changes in a rapid, almost instantaneous fashion. And it quickly became apparent that some changes actually improved our students' education while others didn't work so well. So we'll be eager to learn about our attendees' experiences on these fronts. In today's session, we'll hear about how AAHCI's members in the MENA and LAC regions, including Lebanon and Lebanon and Brazil, are adapting to moving medical education forward in this new era and managing the disruptive transformation. Before we begin, allow me to introduce our 2 esteemed guest speakers. Professor Milton Martins graduated from the University of Sao Paulo Medical School with a residency in internal medicine at the Clinics Hospital, FMUSP. He did his postdoctoral studies at Harvard Medical School at Harvard University from 1988 to 1990, and at the Beth Israel Hospital and Children's Hospital in Boston. And speaking of connections and what a small world it is, Dr. Martins, I noticed that you and I did postgraduate training not only around the same time, but at the very same hospitals. Dr. Martins was president of the Brazilian Association of Medical Education from 2004 to 2008, and he is currently full professor of general medicine at USP and director of the general practice service at the Clinics Hospital. He is also the coordinator of the Medical Education Development Center there and president of its educational committee since 2019. Additionally, he's been coordinating the medical school's accreditation system since 2017. His research areas of focus are asthma, chronic obstructive pulmonary disease, medical education, and health promotion. And followed by Dr. Martins, we will have Dr. Umaya Musharrafia, a family physician and infectious disease specialist at the American University of Beirut Medical Center. She's director of undergraduate clinical education at the school and a medical educator. In addition to her clinical specialties in practice, she has a master's degree in public health and service management from the London School of Hygiene and Tropical Medicine and a master's degree in medical education from Keele University in the UK. Dr. Musharrafia is a full-time faculty member at the professorial rank and is interim chair of the Department of Family Medicine at the same institution. She's also a prominent researcher and has many published articles and papers with special focus on infectious disease. Note that each speaker will present for up to 10 minutes, after which we'll have a facilitated Q&A. And note also you may type your questions in the chat box or ask questions live during that portion of the session. We'll do our best to get to all of the questions before we move on to the interactive activity afterward. Professor Martins, please go ahead.
Good morning, people in America. Good afternoon, people in Middle East. I'm very happy to be here, and I'm going to share my screen in order to make my presentation. Okay. It's very important to start saying that Latin America has been severely affected by COVID-19 pandemic. Unfortunately, Brazil ranks second in the number of people who lost their lives due to the pandemic. And we have already more than 21 million cases of COVID-19. Everybody knows that a sudden and radical change in medical education around the world started in March 2020, when COVID-19 caused a dramatic increase in hospitalizations and deaths. Educational institutions in many countries decided to move to remote teaching. In Brazil and other countries of Latin America, faculty and students were not well prepared for virtual learning. These changes had to be performed very quickly, and many obstacles had to be removed. First of all, we were very worried about moving to remote teaching because there are a lot of competencies that are impossible to acquire entirely in remote teaching. In our medical school in Brazil, we follow the framework of competencies of the Royal College of Canada. So we believe that a medical expert must be a communicator, a collaborator, a manager, a health advocate, a scholar, and a professional. And it was very difficult to keep everything going in remote learning. But we had to do it. And what we have learned at the side of the teacher, the teachers, we learned that it's very important to develop a program of faculty development. We had a Center for Development of Medical Education here at our medical school. And this center helped all faculty with new technology. Competency with technology for online teaching is very important. It's also very important that faculty understands that there is a huge difference between planning online and face-to-face sections. And we also learned that we deliver the same content in remote learning. We increase very much the cognitive learning loads of medical students. And it was also experienced that it was not easy to adapt student assessment to virtual environments. So faculty development in this new area of new medical education is very important. But we also learned that it's very possible to use active methods of teaching and learning in online environments. Both live and previously recorded classes. We used flipped classroom, small group learning, a lot of kinds of small group learning, problem-based learning, team-based learning. Everything could be adapted to virtual learning, virtual consultations, and also virtual practical exams like OSCEs. What have we learned concerning medical students? Latin America in general, but Brazil in particular, have huge social differences. São Paulo is a mega city with very different areas, rich areas and poor, very poor areas. And we have students that come from all the city, all the state, all the country. We have a very strong program of social inclusion here at our university. So differences in access to high-speed internet and computers at home among students was a very important issue. We have to do special arrangements with financial and technical support. We send them computers, we bought for them high-speed internet in order to all of them have the same chances and opportunities in this time of remote teaching. We need to increase social, student support, psychological support, health support, financial support, and the most important thing is that we need to keep a stronger connection with the students. Concerning students, medical students in Brazil, we did a study that was already published in PLOS One, asking students at the beginning of the pandemic if they wanted to be volunteers, to join the health team to help the fight against COVID-19. And we wanted to evaluate the motivation of medical students to be part of health teams. We performed this study in the beginning of the pandemic, in March 2020, when there was only a small number of cases of COVID-19 in Brazil. And we sent a questionnaire to medical students from all the country, and in only 3 days, we received more than 10,000 answers. And we sent them a questionnaire with 28 statements, and the 3 statements that were more correlated to the desire to be a volunteer was these 3. It is the duty of medical students to put himself or herself at the service of the population in the pandemic. I'm willing to take risks by participating in practice in the context of the pandemic. And I will be a better health professional for having experienced the pandemic. And we were very happy with these results because our conclusion was that medical students in Brazil are more motivated by a sense of purpose or duty, altruism, perception of good performance, and values of professionalism, more than by their interest in learning. And how about medical education after the pandemic? We strongly believe that we must evaluate the medical student, assess the medical student, what they have learned and what they have not. We must evaluate the medical student. But we also believe that medical education will continue to be a mainly presential enterprise. Interaction with teachers, peers, and patients, building an ethical professional identity, presence of mentor and role models, training of multiple skills. We need the presence of medical students to reach all these goals. However, part of the content can be delivered in virtual environments. The proportion of each one is a challenge. We must discuss it maybe after evaluating what happened in these almost 2 years. But changes in medical teaching due to the pandemic are a strong opportunity to open new doors of innovation. And that is our main challenge. Thank you very much for your attention.
Thank you so much, Dr. Martins. I'm sure we'll have some really interesting questions for you later. And Dr. Musharrifia, you can go ahead.
Okay. So, okay. So are you able to see me? Okay. Okay. So I started my presentation with this quote: "The pandemic is not a revolution in medical education. It's an opportunity for us to improve, to learn how we can improve medical education." And so I will start with my first slide. Habiba, you will, okay. Okay, as COVID-19 hit us, so there was definitely a disruption in education, and we realized that there is a need for change, and the need was necessary and urgent. We had to rethink and redesign the educational offerings, and we thought whether we need to be innovative because we are dealing with a new thing now. And we definitely, as other schools, we had to shift directly from the traditional mode of teaching to the virtual, from seminars to webinars and so on. And the question was, next slide, please, next slide. So the next question was, COVID-19 definitely has launched digital revolution, and the digital tools appear to be the solution. But the question was, are we prepared? So my colleague was talking about students and faculty were not prepared. From our side, I think students were a bit or maybe more prepared than us, because to begin with, the change should have come before the pandemic, because everything has changed in economics, in social studies, and culture, but in education, it has been stagnant for a while. So the change should have come, but COVID-19 made it quicker and to occur swiftly. So, no, please, next slide, please. Okay, so I think what we think is that our students, they needed the hyperclass. They are the millennial generation. They are the generation who are hyper-connected, hyperlinked, mobile. They use a lot of mobiles and technology, and they are self-tailored, proactive. And we thought that this made them a bit more prepared than the faculty, and they needed the hyperclass. The hyperclass is the hyperspace. Please click next slide. The hyperspace is, if you look at your millennial student, he wants to work from everywhere. He wants the space. He wants to work from his lab, from his room, from his laboratory. So they needed the hyperspace. They needed the hypermedia. They are always on their media. They are always on their mobiles, on their computers. So they needed this media, and they knew that they needed the hyper reality, and they were skilled in it. They used the augmented reality, the virtual 3D, and they were more skilled than the faculty. So what I think that they needed something for the hyperclass, because they were really a little bit, even maybe more prepared than the faculty. So the change should have come, but COVID-19 made it quicker, and the students, I think, were more prepared than the faculty. Next, please. Next. So the rapid evolution to digitalization should occur in a very short time. And the problem is that we were implementing and we were learning at the same time about the challenges and the barriers. And this was unprecedented, because we are implementing something that we don't know much about, and students and faculty needed technical assistance, and the university at whole needed to reinvent and to reinvent itself in record time just to keep the campus operating. Next. So we wanted to design something, to design not only a course, to design a learning environment, an online learning environment, because we know that in learning, it's not only chunk of pieces that you put on Moodle. You have to create the cognitive, the emotional, the motivational, and the social aspects of learning. So the faculty were asking, what learning should be relevant to the students? In what social context? Should we follow several methods or one? How can be motivating? We need more instructional support. So at this stage, as my colleague said, we did not have the instructional support, but what helped very good is the collaboration. So there was a lot of collaboration between many teams, between the students, between the faculty, between the administrators, between the IT people, and we were having continuous meeting to take care of this change. Next. So which aspects should be considered while delivering online? So some faculty were the coordinators of the courses. Many used flipped classes, as my colleague mentioned. Some chose synchronous live versus recorded. TBLs were used small group discussions through the open option of breakouts through Zoom and Microsoft Teams. Many faculty used multiple modalities, multiple modes of delivering the material, like content, text, like videos, like several modalities, and there were the question was how to give feedback to students and how to communicate, and we had to agree on this at the beginning, how to give feedback to students, how to communicate with them, WhatsApp, email, and how to make sure that the students have the ability to self-monitor the pace that we are going through. So these questions were coming out, but peer-to-peer help and collaboration. As the pandemic was going on, we were improving and we were learning from our experiences. Next, please. So student aspects, if you look at the students, what something is important that we saw, a few points that I will mention is that there was definitely a technical challenge. In Lebanon, we don't have only the COVID. At this time, there was the financial crisis Lebanon is passing through. We had a lot of logistic problems. We had a lot of current electric problems, electric interruptions. We had the cost of the internet. And so these were extra problems that we were facing in Lebanon, but the technical one was one of them. We wanted to ensure that all students are equitable. We had students living in remote areas, and we had to make sure that they have the access to medical education. This was a challenge. Many of the students mentioned that they had difficulty in attention. They felt boredom, lonely. They were unable to self-organize themselves and lacked time management. So these are problems that we noted. Also, they complained of lack of interaction, lack of socialization between themselves and between the faculty. Some of them complained that they have unfavorable home environments for learning. And so they don't like to study at home, they like to study at the university, and this was a challenge for them. And also we noticed some mental issues arising, like anxiety, like low moods. So these were among the problems that we noted. On the positive side, we saw some creation from the students. For example, when we talk about hands-on experiences, I will mention what some of the students did, and this was really a creation and innovation. And some students said that online is the best for them, online teaching, and they prefer it to face-to-face. So these were the challenges of the students with some positives and some lessons that we have learned. Next, please. From the faculty, the transformation was stressful. Thanks to the EPIC, we have the electronic medical record that was introduced in 2018 at AUB, and this was a very sophisticated electronic medical record. So we had to learn and get skills of technology. So the faculty this was a prerequisite, and it helped because the faculty were feeling that the computers are kind of friendly, not like before. So the EPIC prepared us. We had the faculty suffered from, this was stressful to faculty, this change. Also, they lacked instructional designs, as my colleague mentioned. Some were not comfortable with online settings, and something came up is emotional challenges. So they were struggling between boundaries between work and home. So many times the sessions were not running as usual because of lack of electricity for some students, or so they had to postpone it to later that day at night. And this was a challenge because faculty really got tired because they were no schedules and a lot of challenges with the families and so on. But the main difficulties were mainly computer knowledge, and sometimes they had some problems arising instantaneously, and they needed someone, IT person, to be around them. Students helped, as I said, they are technically good, so many times students help. But on the other side also, some faculty felt that it's a new experience and as if they are self-renewal offering of the service. And a couple of faculty mentioned that they felt more empathetic toward the students, despite the distance, the lack of proximity, but they felt that they are closer because maybe it's, I don't know, but they felt that they were able to get to know more about their students. Next, please. So at the level of the university, again, this change was, there was a need for a short-term unbudgeted financial costs. The university had to improve on existing digital capacity. There was also a promotion or more sessions about how to develop programs to support online instructions. And there was a general promotion of the culture of digitalization between the various teams. Next, please. So the major challenges were with assessment, because we felt that the students' assessment should be realigned with this content of teaching. Online learning objectives are low on Miller's pyramid, and if you can see, if you please click Habiba, you can see that the knows and the know-how these are measured with the online. But if you want to measure a practical skill or a show-how, we cannot do it on online. So this was really a major challenge. Although we have many modalities of assessment like MCQs, essays, short answers, but still they do not measure the practical and the clinical skills. And there was the challenge also, even when doing the tests for the know and the know-how with MCQs, we had the challenge of the fair assessment among students while assuring not cheating. So we incorporated the Respondus, which is a software to check on whether students are cheating or not. But still it did not, it showed the trend, but it does not give evidence. So sometimes we went to psychometric analysis, like if we have a question that has been given last year or the year before, we did some psychometric analysis to see whether this year the score was higher, much higher, and whether there is cheating. So the assessment was really troublesome for us because we have to be fair. We have the software and we have the psychometric analysis, which helped a bit. Next, please. So as I mentioned, how to assess was the practical skills was the main issue. So the students in many sessions in the clinical, we were doing the clinical skills online, but we were asking the students, like I want to teach you how to do hand hygiene, I show you a video, and the students would go home and then they would do hand hygiene and they would video themselves and bring it back to us and to the tutors who will discuss it together. The same thing with physical examinations. For example, we tried our best, like if you want to examine the liver on a family member whom they are staying with and there's no problem with COVID issues, so they would video. Okay, so there was also the question whether we need to stick to these high-stake examinations and replace them with ongoing multiple low-stake assessments. So this was a question that came up by the end of the year, and one of the challenges also how students are going to evaluate the online courses and the evaluators themselves. Maybe we have to change the rubrics. For example, if I want to evaluate a teacher on online, maybe I have to change, for example, whether he is present, whether the material is accessible, whether he is technical issues are good, whether he can manage the session, and so on. So these are questions that came up with the COVID. Next, please. Mitigating factors, what helped is that we had the pass and the fail system in the preclinical years. This helped. We had the learning communities. These are sessions that start in Med1 and run all through. They talk about time management, emotional intelligence, many paramedical topics, listening and the reflections. And this helped the students because they were kind of able to reflect and to talk to their advisors. We have a very good mentoring system and advising that help the students. We have a wellness to take care of the burdened student and the anxious, and they all turned online. This helped a lot. And for next, please, Habiba. So lessons learned is that if we want to deliver online, we have to be effective. We have to institutionalize online education. It should not be a support. It should be instituted. We need to build capacity building programs to improve quality of online teaching. We need policies and guidelines for online learning. We need collaboration. Hybrid learning is important and it should harness the potential of technical problems. And maybe we need to change some high-stake examinations to ongoing assessments. Futuristic outlook, what would happen in the future, the last slide please, is what I think will happen is that the pandemic will stay. It will change how our future physicians are going to be trained. The technology will reshape education. hybrid learning is likely to stay. I would think that universities need to prepare for an interconnected world. So I think we will be dealing with the global student. There will be greater cooperation between international institutions to overcome barriers of geography. We have to enhance humanity, because we are dealing with machine learning or similar. And I think that we will reach a time when we have the global student. That is a university. If you register in that university, you will be connected to several ones and you will become the global student. Thank you.
Thank you, Dr. Michelle. Yes.
Thank you.
Thank you to all the panelists. And then we're going to open the floor for the Q&A. And again, you can put your questions in the chat box or raise your hand. We have any questions?
Yes, I do. I raised my hand. I don't know if you can hear me.
We can hear you.
All right. Fantastic presentation. Really, my question focused on what really the online platform is not yet ready to provide. That is that aspect of human touch, caring, not just absorbing content, but really caring for the patient, which you require physical presence with the patient. Obviously, that can still be developed virtually using, actors or animations or scenarios. But I wondered if both speakers will talk and address the issue of, caring and the human aspect of healthcare.
So the question is for me.
Yes, for both of you.
Okay.
Yeah.
So in fact, there was some interruption in the sound. I didn't hear all the question, but that's why I mentioned enhance humanity in my last presentation, because I think with dealing with machines and reading with computers and applications and videos will keep us away from our patient. I think we introducing for example, sessions like the learning community that we are doing, enhancing the ethical and professional courses, and maybe having a good mentoring system might help. I don't think that computers or the hybrid nothing will replace the human touch, nothing will replace the communication skills and the ethical and professional behavior. That's why this is an area that is kept, even if artificial intelligence comes, it will not be able to accomplish these capacities. These are for human. That's why the issue is to enhance humanity from the day one of medical school and to enhance professionalism and ethics. I think this, if they go hand in hand with a good mentoring system, maybe I think we will be able to draw the line between what should be learned through mentors and teachers and from the technology and the digitalization.
I agree with Maya. I don't believe that a medical course will be predominantly online. I don't believe. I think that the building of a professional identity, the need to learn how to care for patients, the relationship with mentors, with role models, the acquisition of skills must be in person. But we must learn about what happened in the last 2 years, and we think that we can do a lot of innovation in medical schools. So I agree with both of you that we must go back to the patients. I can talk about our experience because we stopped only the first 4 years of our medical programs. The last 2 years that we call here internship, students continued to take care of patients, to go to hospitals, to go to health units, and they had a very good experience even during the pandemic. And now the students from the first to the 4th year are coming back, and they are very happy to be back. And now we are going to evaluate what happened to them. And they want to learn clinical skills, history taking, physical exam. They don't believe that what we did remotely was enough for the acquisition of these skills. But we must evaluate what happens. And but I agree with the idea of the need for increasing collaboration and the global medical students. This is very important for the future. I agree with you.
And one thing I'd like to add is what will enhance humanity and the care for the patient is role modeling. So the role models are very important in the medical profession. It's not how much you teach ethics, and it's not how much you teach professionalism and the humanity. It is the way how you present yourself in front of the patient and in front of your student. So I think the role of the teachers and the role of the physicians in being good role models and in teaching students how to deal with negative role models, I think this is very important.
I guess there's a question in the chat. Habiba? Yeah.
Yes, there's a question in the chat from Rania Sakar. Do you think that not doing high-stake exams can affect the acceptance of our students to continue their residency either in the US or Canada?
So if you have ongoing low stake evaluations, but they are ongoing, it's like when you have multiple formative assessments, it can lead to like a summative assessment. So and I'm sure that the acceptance of the students to universities will change with time. It will not stay related to the grades, because I think they will extend the acceptance to include other opportunities. Now with the digital era, I think even the acceptance will change to the universities. So my belief, if you are following well on your student and you have ongoing multiple assessments with good follow-up and good mentorship and advising, it should not affect. It should not affect. But if you have, if you are replacing the summative with like 1 or 2 low stake examination, yes, it will affect. But my vision is that in the future, the criteria for acceptance will change also with the digital era.
Thank you. I guess now we will, in the interest of time, move on to the discussions in the breakout rooms. Yes. And this is the no turning back portion. I'll just briefly read the questions, but they can be gone over again in the breakouts to address first, the new teaching tools of the pandemic. What worked better and is here to stay? What worked better than before the pandemic? The second, real failures of the virtual platform. What didn't work and why? Next, going forward, can we accommodate differences in students' learning styles and preferences? And finally, how can we prepare the faculty for the reboot of on-campus life and curricular adaptations?
All right, so everyone will get a prompt pop-up to join a breakout group. We will have two and each one will have a facilitator to guide the discussion. So.
And until what time, Habiba, do you know we will have these breakouts?
I will send a little warning when we're coming close to time, but I think 10-15 minutes should be good for discussion.
Okay.
All right, here we go.
Okay, so I guess we're going to move along to a general discussion, and we'll have the reports from our breakout groups, and I guess I will start. First, there was an interesting comment that we need to adapt our educational tools in this era, and that we don't even really think about it consciously, but when we're interacting personally with students, we have advantage of our personality, interpersonal interaction, our charisma, and this is something that we can't have on a digital or virtual platform. So we have to adapt those and use other tools or enhance the digital medium. Dr. Martins commented that what worked pretty well if you had a small group class, but the large groups didn't work so well virtually. And we had a similar experience with our PBL groups, our problem-based learning discussions, that were difficult to adapt to the digital platform. Online assessment can be very challenging. We have to find new ways to do that if we're going to continue it. And Dr. Asma from LAU remarked that there were certain disciplines and clinical specialties that worked well. For example, biochemistry, radiology, pathology, where digital slides were used. But regardless, even though we had assessed the students and how they did during the digital era of the pandemic, and for example, in pathology, it seemed to go quite well. Some students just prefer to be on site. So even if it was an optional lab, they would come in for that. And as was mentioned before, a lot of students are just so happy to be back on campus and be with each other. And as Dr. Martins mentioned, if we didn't believe in different learning styles before, we believe it now, because the pandemic really brought that into clear relief. So that's about it for our group. Do we have comments from the second breakout group?
Yep. So I will take your last sentence, because from our side, Dr. Musharrafieh thought that the learning styles, though they may be variable and there are many, but we should leave this concept of people having different learning styles and try to address in different ways learning itself. But we didn't have time that she elaborates more on her thoughts. Maybe after I finish this brief summary, she can comment on this. Also from Brazil, Mexico, and Lebanon, LAU and AUB, we had different, though convergent thoughts on what worked well, what didn't. We all thought that technology was excellent, at least it exists, and it helped us continue education. Otherwise, we wouldn't have been able to continue that education. And second, we all realized also that there were failures, and these failures were related mostly to the technical glitches, mostly, and also to some formats, which, like you said, didn't work well, like the large groups. Also, the online learning wasn't good in real experiences. So it seems that students and faculty alike, though they liked somehow the online platforms, but they wanted to enjoy the warmth of the socialization. So going forward, most of us thought that we would go hybrid, keeping these technical platforms for the preclinical years where patient interaction may not be that needed, and be immersed in real patient experiences, and to use simulation as well to prepare to these real life experiences. So this is in a nutshell what we discussed. It was very rich and nice. Dr. Musharrafieh, do you want to elaborate a little bit? We have like 2 minutes from our side left.
So going back to the learning style. So in the literature, there is no, as mentioned by Nancy, that there was some doubt about this, but I don't think the online will make the learning styles more يعني هيك بالعكس. I think it will engage all people with all learning styles. Let's take the visual. The visual, if he's studying online, he's seeing the videos, he's seeing the screen, he's seeing the text, he's happy. If you take the oral or the auditory learner who he likes to listen, he has the headphones and he can just hear. If you want the social, you have a team on, you can work with teams on online. So what you are left with is the learning style, the persons who are, they want hands-on. I think this one will not be satisfied. With the hybrid, I think it will work. But all the other, even if you believe in the learning styles, the online will satisfy most of them, all of them, if only one, maybe the kinesthetic one.
If I may, Dr. Shadid, share with you the few data that we have on LAU students, because after the first 3 weeks of return to campus, we administered a survey, and most of the students from all 7 schools, including the medical school, the majority wanted to go hybrid. And the second majority was toward in-person education. I don't know if it's because we failed. I don't know if we failed, but also, as I said, students enjoy the warmth of the social interaction. So many of them were in the library listening online to the lecture, but they wanted to be on campus.
Yes, yes, very true, Sola. Thank you.
Right, thank you. The floor is open if anyone has questions, comments.
Dr. Martin, I think.
My comment is that the situation is the same in Brazil. The majority of students want to go back to campus, but they want a hybrid teaching, both part virtual and part in person. I think this is one very important lesson of this year.
Thank you.
One theme that, oh yes, Dr. Aoki, did you have something? Yes.
No, I just wanted to say that students, they love challenges, especially medical students. And when you propose them different things, I think they're very enthusiastic about it. So for the staff, one of the biggest challenges was how can you change your mode of teaching? And for them, for the students, they miss the patient, the contact, the hospital. I think whenever you enter the hospital, it's like entering, you know, a sacred place. And I think they miss this a lot.
Sure. I think a number of people mentioned that, maybe not surprisingly, there were emotional health and mental well-being issues that came up, and not only for students but also faculty, and we're trying to look at this now, but you know, I think maybe shouldn't we have anticipated that this would be anticipated more, that this would be an issue. And I'd be interested to hear anyone's thoughts on how to handle this going forward.
Valdez, maybe?
Yeah.
Thank you. No, I want to comment on the use of the hospital. In the past, we rely a lot on the use of hospitals, the place in which clinical training happens. But we learned, because we have limited access to the hospital, at least in our system. And actually, one of the hospitals was entirely devoted to COVID. With the students, we learned to use more or take advantage of the other clinical spaces, the office room, the ambulatory settings, the prevention clinics. And actually, we found that the development of skills, communication skills, and exploration skills, even professionalism, we can develop it in those spaces. I know this is not new, because a lot of people have been saying this, try to use less the hospital and use more the other clinical settings. But this pandemic, at least in our case, put us in that position in which we will decrease the use of the hospital as the place in which most of the clinical training happens. We learned that, at least for the students, a lot of the skills that they need to develop, that you can learn it in other clinical settings, not necessarily the hospital. I'm talking about the hospital with the patients in a room, in a bed, because sometimes the clinical centers have the other environments around them. But I think we need to learn more on how to use other clinical settings to the training. Thank you.
Thank you. Yes, and something surprised us. I heard comments from students that even at a time when COVID was raging and we had a decreased capacity of students in the wards, and there was a time they weren't all being exposed to COVID patients, and yet they said that in some of those settings they had more time, they had more attention from the attending physician, and so they benefited from that more, almost a one-on-one teaching, as opposed to when we had full capacity of students. So there were some surprises.
Yes, can I mention something?
Sure.
So in one of my slides, but I did not elaborate because of the lack of time, I elaborated that our attention to students and our focus has sharpened. Yani I know many faculty, we got to know more their students, maybe come in more the social aspect, their learning styles, the more we have known more about them, and our knowledge has focused better in some cases. So yes, there are some advantages, but we have to work on the disadvantages and the weaknesses that we have and the lessons that we have learned, so that to be prepared, hopefully, for the better and not for any more COVIDs or similar viruses.
Thank you.
Thank you.
Going back to the mental health? Yes, Dr. Martins, go ahead. Yeah.
Okay. I would like to make a comment on the differences between teachers and medical students, concerning if the medical students are digital natives and if we are not. What we saw is that many medical students are digital native, but surprisingly, not all of them. But they helped the teacher a lot. Many teachers, yes, to use technology needed the help of a medical students, and a connection between the student and the teacher increased. I think that you are agreeing with this. And,
yes, sure.
But for digital natives, I have some concerns because they open a window and then another window and then another window, and we must be very careful about if they are losing some competencies, such as metacognition, critical thinking. Maybe they should read a lot of entire papers, an entire book, a literature book. They are losing something. They are, yes, they are not only gains, they are losses also.
Yes, I would say that there is an element of attention deficit in this millennial generation. I agree with you, but hopefully, we hope that because these millennials also like to work in teams, so maybe this can compensate. So on one side, they are hyper-connected, they are hyperactive, they are proactive, self-driven, but they will like to work in teams. So this is one aspect that is good. But on the other side, as you mentioned, we might be dealing with a mild element of attention deficit. Maybe. So they are new students. They are the new generation.
I agree.
Yeah. Yeah, we have to adapt ourselves and our teaching modalities in a sense to them. So I was just going back to the mental health issue that we had just begun. Did anyone have any comments or input of how they're approaching that or how we should handle it going forward?
So at AUB, we have a wellness program. So this wellness program, the aim of it was to take care of healthcare workers, and recently we included the residents and students. So it's a wellness to make sure that physicians do not suffer from burnout or from mental issues. We dealt with this program during the COVID with the nurses when there was the peak of COVID, and we offered also for students and residents. So they can ask the wellness program, and then they have counseling sessions online during the COVID period, and now maybe they can come in person.
Dr. Musharrafia, what are, beside those who need to go on to counseling, what are some of the basic elements of that, the wellness program?
Oh, so stress management, they would undergo training about coping mechanisms. They would include exercises like yoga and Tai Chi. And also we have a program run by one of our physicians, Dr. Maya Romani. She is in charge of this. So they undergo a whole package of stress relievers. And in cases where we find that they need a psychiatric help, we refer, but most of them, they are dealt with within this program, starting from stress management, starting from exercising. They teach them how to cope with all the stresses of life. And they provide exercises, acupuncture, and other programs. I don't know them all, but these are among the sessions that are given.
Very interesting. Thank you. Yes.
Hi.
Go ahead, yeah.
Hi, thank you for this insight from AUB. What we did at LAU, in Beirut, I see some international people after we had the explosion and the blast, and the medical students, residents, nurses, after seeing patients suffering on the wards, for instance, for my specialty pediatric oncology patients, we felt that they needed some kind of personal development support, how to handle stress. So we organized with an expert in Nice in France. He specializes in staff, physician, doctors, medical students, burnout, and he specializes in how to handle stress at work for doctors and residents and students and nurses as a team, and teamwork under stress. So we did 3 very good comprehensive sessions with him for the staff, healing the healers or caring for the carers, which we did at LAU for the pediatric team and all the students, residents that were going through this. And it was very helpful. And even he at the last session, we involved some families as well, just to get the vision of the families and how stress, and burnout how does it interfere with patient doctor relationship and staff among each.
Yeah.
So that was really helpful. So I wish they do it as part of the curriculum, as a standard curriculum, not only for acute situations like what we had after the Beirut blast. It should be, yeah.
The medical school is stressful enough without these additional.
Yes, absolutely.
We have for residents, one thing, Nancy, we have for residents the balance. We have the balance sessions. I don't know if you have them at LAU. So all residents now in family medicine, and now we extended to internal medicine, they have sessions monthly for what we call balance, and where they express any, this was running during the usual days. Not now, yani not only now, but they would talk about any case that triggered something in them, and they would listen to others, how would they manage it. And this is also very fruitful. These are very fruitful sessions because they make residents talk out, see what others would do in such situations, see that they are not lonely in this problem, and so on.
Yeah, thank you, Dr. I think we have to move to Dr. Aoki, Professor Aoki. She has her hand raised. We have similar programs, Umayya, at LAU for the medical,
sure.
for the residents. Yes, but for the sake of time, maybe we should move to Dr. Aoki.
Oh, Dr. Bahous, I think Professor Valdez was before me. I just wanted, I can say this when we wrap up, okay?
Yeah, yes, go ahead, Dr. Valdez.
Thank you. No, I just briefly comment that before the pandemic, we start with the learning communities approach. That means that we create this academic society. These societies or communities are integrated with faculty and students at the different levels. And the approach is through the social theory of learning. We learn in the same way we learn in a family. We learn about different roles. But really, during the pandemic, this academic society were very useful to keep the sense of community, of being part of something. This it was a strong support for this emotional health of the students, because knowing that they are part and being supported by other students that are facing the same or facing a different level, because we have students from first year, second year, third year, and the faculty around them and working as some mentors really prevent a lot of the issues. Although we have in place, as the other colleagues mentioned, a lot of wellness programs. And one instrument that we use a lot was the wellness checking. Every time to time, the students have to check within the societies that they are well, asking frequently how they are. That's not way to be reactive when somebody's having trouble. Try to that they have this reflection on their own wellness, how they are feeling. So we developed that kind of instrument to be aware of not just us, but also students, kind of self-awareness instrument of how they are doing. Thank you for letting me share it.
That's great. Thank you. Probably, I'm afraid we'll have to go on to conclusion, and we're close to running out of time. Thank you, everybody. And I'd like to ask our organizers just for their brief closing remarks, Dr. Bahous and Dr. Aoki, whoever would like to go first.
You can go ahead, Dr. Bahous. I'll go after you.
Thank you. I just want to thank everyone, all the participants, AAHCI for giving us this opportunity to discuss, and our partners at USP. Thank you. This really was very helpful. I learned a lot personally, and I hope everyone also is leaving with something. Thank you very much.
Thank you for the organizing committee. It was great opportunity to see you all and to share experiences. Thank you, Sola, and thank you all the professors. Thank you.
On behalf of the Latin American Caribbean region, I would like to thank all the participants. It has been a very joyful and productive morning. And I think the final message here is the beauty of the pandemics, despite its tragedy, was how we detected the real role of the medical student, not only as a passive medical student, but also part of the medical education. I think this is the big lesson, at least for me. And I think the other aspect is when you choose medical school, you choose, a very difficult path. And during a pandemic or a crisis, I think you have to wake up this true path. Okay, so thank you very much. Shukran, and obrigada in Portuguese. Okay, thank you. Thank you for the association for this invaluable support.
Obrigada. Thank you, everyone.
Thank you, Nancy.
And yes, Dr. Martins, did you have any closing comments?
Oh, only thank you very much for the invitation. It was my pleasure to be here. I learned a lot.
Me too. I learned a lot, and it really, one of the delights of this was meeting everyone and getting in touch and see that we have a lot in common. And I think going forward, we have to, as everyone said, keep an eye on the effects that our various methods have, not only on the learning process, but also the emotional well-being and motivation of our students and faculty. I need to announce, please note everyone, the link in the chat box, and I hope you will be joining the full meeting, the annual meeting, and register if you have not already. And join us this week. There are some exciting sessions, the President's Council on Health Security, Preparing Academic Health Centers for the Future, and the roundtable discussion on politics of health. Thank you again for sharing your experience, and to all of our attendees and panelists, and we'll look forward to collaborating again in the future.